Today we have Dr. Tran from UC Davis here to talk a little bit more about point-of-care diagnostics in the field of burn medicine and trauma care. He did his undergrad in biochemistry and molecular biology at UC Davis. Yeah, at UC Davis, and then he did a PhD in comparative pathology, also at UC Davis. After which he did a postdoc at the National Institute of Biomedical Imaging and Bioengineering. And simultaneously, he also completed an MS in pharmacology and toxicology. He's currently an assistant adjunct professor and associate director of point-of-care testing center for teaching and research at UC Davis. He's a member of the American Burn Association, American Association of Clinical Chemistry, National Academy of Clinical Biochemistry, and the Society for Critical Care Medicine. Dr. Tran is really interested in learning about different diagnostic and management of sepsis and burns, and also antimicrobial therapy infectious diseases.
Great.
Let's talk about it.
Thank you, Amy, and thank you for having me here today. It's definitely very good to see that there's such a group here at Berkeley. I actually had to go talk to the vice chair of biomedical engineering, and I said, I want a group in point-of-care testing up there too where these students get involved. There is interest, so maybe we can talk about possible collaboration between two groups in the future. And so a little bit of other background that may relate to all of you is I also am an instructor of record for the Biomedical Engineering Department's Clinical Applications course for biomedical devices. It's the first class at Davis, at least. It sounds like there might not be a class here at Berkeley too, but we teach a lot of the engineering students the actual clinical sciences. Effectively, med school, first year, second year curriculum truncated into half of a quarter, and the next half more on bioinstrumentation. It's intense. But all the students do very well, actually. It's one of the best classes. So we'd love to either share the class with you down here, whether it be video conferencing, or even have you guys come up there. So definitely something we are interested in. But today's talk is kind of a little bit different, more so point-of-care testing, but in a unique population known as burn patients. And we played around with this, a lot of point-of-care testing. We've played with smart devices and also with pathogen detection. Well, the first question that you might have is why burn care? Number one, I have a PhD in comparative pathology. How does that relate to burns? My path there has been unique. I actually was roaming around the hospital aimlessly looking for infections with my pathology background. The first person that told me that trauma surgery isn't a great population, they said, go talk to those strange guys upstairs in burn surgery. So I went upstairs and met the burn director, and she said, yeah, let's try it. And kind of started off my whole entire academic career in that area. Well, in terms of relevance and prevalence, we see that, of course, the MAC has betrayed me here in terms of formatting, but in short, the global prevalence of, actually, I think I've seen this issue before you go log in and log out. The prevalence of burns in the world is actually quite high. It's quite high, and it's about 4 million. In the United States, it's typically due to just house fires, industrial accidents, and unfortunately, which is about a third of populations that get burned, admitted to our U.S. burn centers, is actually due to drug development, drug manufacturing. So about a third of them coming to our burn centers in the United States are due to methamphetamine development. So if you look at the chemical process, are there any chemical engineers here? Have seen the chemical process? Well, it usually involves an endpoint of red phosphorus, usually a flammable compound, and these people are amateur chemists, and they get burned. And sometimes other patients come in with hash oil. Hash oil is another manufacturing method that requires a butane or alcohol source to extract the THC from the marijuana plant, and that's flammable as well. So we get a lot of those, but in other countries, low resource settings, it's highly prevalent. People still cook in open fires. Mexico, we have a lot of kids that get burned from playing around the open fires in their kitchen. They get sent to our Shriners Children's Hospital to be cared for free. Burns have also a very high acute morbidity. Of course, chronic morbidity is they can't function too well because of their scars. But in terms of acute, they have acute kidney injury. This is when your kidneys don't work well. They can go into renal failure, requiring dialysis. 45 to 58% of these patients get. That's a big number. Another big one here is 97% of patients with 20% or more burns, 20% is about 2 arms worth, they'll get a severe infection called sepsis. Are you guys familiar with the word sepsis or heard of sepsis before? Okay. So this is pretty big. We see that burn patients with AKI or acute kidney injury have a 3 to 5 times more likelihood of dying. And we also see that 75% of burn-related deaths are actually due to invasive infections. So these are big numbers and we want to reduce it. Well, talking about other factors, high cost. It actually costs $17,000 a day in our ICU. That's not including medications and procedures. And burn patients stay on average between 1.5 days per total body surface area burned. So that's quite a long time. We've had patients that stayed over a year in our ICU, not just in a clinic. And on top of that, some of these patients have accrued over $10 million of bills just from the care. We can argue that this may be due to the healthcare costs, but at the same time, these patients require some of the most cutting-edge technologies out there and most expensive drug compounds and devices, and it does add up in the end. Well, successful treatment of burns, however, is actually a very recent development. You think that's been around for a while because people have been burned for quite some time since man first recognized and created fire. But in 1939, a patient with 33% burns was pretty much written off. That was too big of a burn, this guy's going to die. And most of these people that are written off end up dying of what's called organ failure, secondary to shock or sepsis, so their blood pressures dropped too low, they got an infection, they died. However, if you fast forward in time from the early 20th century to today, around 2012, 2013, we finally did an analysis to show that, in fact, today, modern burn care has actually moved our LD50, the lethal dose or lethal burn, where 50% of the population dies, to actually at 80%. So if you have an 80% burn, you have a 1 in 2 chance of surviving, which is great compared to back then with a 33% burn, you have a 100% chance of dying. So we've improved significantly. And this is due to recognizing burn care as a process. We have 3 phases of the burn care process: the acute resuscitation phase during the first 24, 48 hours, the wound healing and infection control phase, which lasts over the duration of their ICU stay until their wounds are healed. And once they're healed, we have the rehabilitation phase. Most of the mortality ultimately derives from the first 2 phases right there. This is where we'll focus for our talk today. But of course, this is not to diminish the importance of the rehab, because anyone who wants to work in that area, that's also a huge area of need for burn care. Okay? So let's look at the acute resuscitation phase first. So kind of recalling back from your physiology, and please stop me if you have any questions, because sometimes we forget that when I'm talking to the residents, they might know something, and I might go fast over something that you might not know, so please stop me. But if you have an injury of some kind, could be a burn, could be a trauma of some kind, your body responds to it. And this is due to the inflammatory response. So you have a bee sting, right? You have that spot there where the bee sting is, it swells up, turns red. This is due to more blood flow. The blood vessels get leaky, so fluids start leaking out. The blood vessels get bigger. This is also that the immune system can get to where it needs to go. Well, let's start thinking about this, something bigger than a bee sting. A 20% burn. Both your arms are burned. All those blood vessels are going to get bigger. They're getting leakier. What's going to happen to your blood pressure? What do you think is going to happen? Go back to your basic chemistry with the old laws where P1 V1 equals P2 V2, right? You increase the volume, your blood pressure is going to do what? Drop. It's going to drop. Great. So it's going to go down. This is also the reason why people who go into anaphylactic shock, their blood pressure drops too. It's analogous to that. Well, let's go over here. We just burned off all the tissue here. The skin is a great barrier to keep the bacteria out, but also keeps the water in. Okay? Well, we lost that barrier. All that water is going to evaporate off now. So combined with the loss in blood pressure due to loss of fluids from migrating out from leaky blood vessels and increase in volume, diameter of your blood vessels here, with evaporative water loss, you're going to have the issue of burn shock. And this is manifested by a significant drop in your blood pressure. When you drop your blood pressure, you have a lot of problems. Okay? We need blood pressure, we need blood to go to the brain, we need blood to go to the organs, and so forth. So it was ultimately realized by 1978, again, this is quite recent relative in terms of medicine, that we have to give burn patients in the first 24, 40 hours massive amounts of fluids to get their blood pressure back to something normal. Charlie Baxter was the guy that came up with this out of Parkland Burn Center. Does anyone know the significance of Parkland Medical Center in Texas? Anyone important that went there? Kennedy, yes. President Kennedy was assassinated, got sent there. That's the importance of this. Baxter, if you guys go to the hospital or see an IV bag, it says Baxter on it. Same guy. So he postulated that you need to give these burn patients 4 mLs of lactated Ringer solution. Lactated Ringer is effectively a solution that's isotonic to blood per total body surface area burn per kilogram body weight. This is the total amount of fluids that that patient needs in the first 24 hours. You give half in the first 8 hours, and the remainder in the 16 hours. This is an estimate. So a 90% burn patient who weighs 100 kilograms will need how much fluids in 24 hours? 36 liters. Is that a lot? How much do we drink, or how much are we supposed to drink per day? Nowhere close to that, right? All right, so what happens if we don't do a good job resuscitating? Well, if we under-resuscitate a burn patient, not enough fluids, not enough blood flow, low blood pressure, we'll have organ dysfunction and eventually death. If the patient still survives that, they have an increased risk for infection, sepsis. It's been shown in animal models that if you don't have adequate blood flow due to under-resuscitation, the blood vessels in your gut get leaky, and same with the lining of your gut. The bacteria in your gut kind of migrate out and cause infections later. And then, of course, we have acute kidney injury, which can progress to renal failure and needing dialysis. Well, of course, you can go, well, just give lots of fluids. That might be better, right? More might be better. Do you think more is better? Trick question, right? Of course it's not. Everything in moderation. So over-resuscitation. Well, you have leaky blood vessels. Do you have a question? No questions? Okay. So leaky blood vessels push lots of fluids in, hydrostatic pressure goes up. What's the most porous blood vessels in the body? The lungs, right? So you're pushing fluids out, you have fluids filling up in your lungs, and ultimately that's pulmonary edema. The patient's not going to breathe well. You're going to have what's called compartment syndrome. Has anyone heard of compartment syndrome? So what's the difference in terms of tissue compliance between burnt skin and non-burnt skin? Or perhaps think of it as a piece of meat you put on the grill. Was the red meat very pliable before you put on the grill or after? Before. You're pumping fluids into the tissue, say my arm here, it's burnt circumferentially. The fluids come in, they start leaking out, you have nowhere to go. You're going to start compressing things like your blood vessels because the pressure differential between inside your blood vessel and the outside will equalize. They collapse. You now lose blood flow to your extremities. The burn surgeons now have to think about amputations. Worst case scenario is fluids start building up in your abdomen, compresses things like your blood vessels in your intestines, your other organs. You have ischemia, or loss of blood flow, in these key organs. They have what's called abdominal compartment syndrome, where a person's burned around their abdomen. We also have increased risk for heart failure. Just like in congestive heart failure in people who have, say, high blood pressure, the heart is dealing with too much fluids. The heart's not going to pump well. We're giving them excessive amounts of fluids. They're going to go into acute heart failure, and this can also lead to pneumonia due to fluid accumulations in the body. So this all comes down to we need to get the burn size calculation right, because that equation hopefully dictates the right amount of fluids we give. The problem is that this component of the equation, the burn size. How do we calculate burn size, and how do we calculate burn size accurately? Can you measure, you can probably measure this one, this burn right here, with a ruler, and kind of get the surface here, right? How about this one, with all these dots and splatters and oil burn? Probably a lot harder to calculate, and it's hard for someone without a ruler to even calculate that. We have rules to go by. We have the rule of nines. Has anyone heard of the rule of nines for burns before? Those that have taken first aid might be familiar with it. It effectively partitions, at least the adult patient, into areas of 9%. So whole arm circumferentially is 9%, so 2 arms is 18%. So the first top half of your leg is 9%, and the bottom half of your leg is another 9%, so your whole leg is 18%. Makes it easy for us to remember, okay? But what is recommended by the burn care clinicians is what's called a Lund-Browder diagram. It actually partitions the body into many other areas. You can actually see the list right here. Again, I'm happy to send this out to make up for this small text, but it partitions it a lot more, helps improve the accuracy of the burn calculation, and at the end of the day, you have to kind of look at the burn patient, enter the numbers, and add the numbers up at the end, and hopefully you have a total body surface area. Well, studies have been done and show that the rule of nines actually overestimates burn size, which means you may give these patients too much fluids if you use the rule of nines. Lund-Browder diagram, it's more difficult to perform. I can't memorize this slide, this chart. So we have to have that piece of paper. Well, you're adding another potential source of error. You're calculating numbers down, adding it up. Unfortunately, I've seen residents mess up on addition. But when the resident is on a 16-hour shift and they've been working that for quite a while, it will happen. Medical errors are a serious issue. Variability. Burn surgeons have a variability in terms of percent, 13.5. The residents, 11.7. Nurses, 32.2. But the important one right here is the 34.5 for other. Other meaning these are non-burn care specialists. The majority of burn patients that come into us are from outside hospitals. So their initial resuscitation is based on potential inaccurate measurements by non-burn care experts. That's important. So we ended up coming up with a needs statement with our biomedical engineers at Davis, and it's burn clinicians require a more accurate method for assessing burn size to correctly calculate fluid resuscitation. And what we found during the needs assessment process was they had 4 desirable features. The first being easier calculation of total body surface area burn based on a Lund-Browder diagram. The capability to take photos so that we can recall the wound appearance. The faculty burn surgeon may not be available at that time to look at the wounds. The resident's the only one to take a look at, but the resident might want to show them what it looked like, because by then, by the time the doctor, the physician, the attending physician arrives, the wounds are already covered with gauze. We want to record pertinent patient information. We also want to be able to automate the calculation of the fluids that are needed to avoid typographical mathematical errors. So these students, of course, pulled off the iPad. Maybe there was an excuse to get an iPad, but we got them an iPad anyways, and did a great job at coming up with this device. This is the main screen for it right here. And we were able to, you push the button, take photo, uses the same features that are very familiar with everyone in terms of iOS-based devices. Take a burn wound photograph. You can then assign the photograph to a location on the body. So if you want to look at arm photos, you can click the arm and pull up all the arm photos. You can type in all the pertinent patient information if you need to. And then we go to the actual Browder diagram, which looks like that. You finger paint in the actual burns, just like so, and you can differentiate between red for full thickness or 3rd degree burns, or blue for partial thickness burns, which are 2nd degree burns, and it adds it up for you. We compared the two. We had the residents do the paper one, and also later do the computer one, and these two were not significantly different from each other, which is what we would expect. And then at the end, we can import that burn diagram into the fluid calculator, and as long as we enter in the other factors in like weight, we can then calculate the fluids here. And it works out quite well. And so where we're going to go with this is we're going to keep working with the workflow with our residents because they are the end users. We work with the Army, National Guard, the 297th Medical Company in San Mateo, the National Guard unit. We're working with the American Burn Association to see if we can modify this for their purposes in terms of getting this through as an educational tool for burn care. And then we're talking early stages with the FDA. It looks like we might have to go down the 510K pathway, which is probably costly, but has to be done. It's an app that is used for patient care. So that's something to think about for mobile medical applications. Any questions? Okay. Well, that's great. I'm able to start fluid resuscitation. I'm able to calculate burn size, hopefully accurately. But how do we monitor how well the patient is doing? That 4 mLs that we start off with for that equation doesn't necessarily account for different patients, right? You and I are different. We will change our physiology differently because of our genetics, amongst many other factors. So how we monitor patients during fluid resuscitation involves hemodynamic monitoring, such as central venous pressure, serum creatinine. Are you guys familiar with creatinine? I've heard of creatinine before. For those that don't, creatinine is a molecule that's released by the body at a roughly constant rate. It's filtered by the kidney. The more it's filtered by the kidney, the more indicative it is that the kidneys are working well. If the kidneys aren't working well, the blood levels of creatinine start going up. So it tells us how well the kidneys are working. Urine output, that one makes sense. If the patient pees more, the kidneys are working. They're not peeing, their kidneys aren't working, right? And that's what we assume. The problem is central venous pressure, which is measured by a catheter that we put into these patients. It doesn't really respond to fluid volume. It was proposed that central venous pressure, because most of the blood in our body sits on the venous side, if we put more fluid in, there should be more there. The problem is, studies have shown in sick people, critically ill people, that you put fluids in that can give you blood, that give you fluids, lactate ringers, the CVP doesn't change. That's not good. Serum creatinine, it's not that great either. Even though creatinine levels are actually still used as the gold standard for determining if a patient has kidney disease. It's not that great because it only rises significantly when your kidneys, the actual functional units of the kidney, the nephron, 50% or more of these are damaged, will then lead to a rise in creatinine. Not that great. It also has a very slow half-life, about 4 hours. So you might not see changes until 12 hours later. So it might not be good for real-time resuscitation of patients. Urine output, interestingly enough, you have altered filtration in your kidney's filtering blood, but if it's altered, you should see a change in urine output. But in fact, in people who are really sick, the critically ill, urine output actually may remain the same. So these biomarkers aren't necessarily adequate for sick people, even though we only monitor them in usually sick people. Okay? So let's first address the problem of fluid status. How much fluids are we giving? Are we giving too much or too little? So measurement of intravascular volumes. We can look at something called myocardial stretching, your heart stretching. Okay? And a study in 2007 by Fries et al. In trauma patients, not burn patients, saw that patients who were receiving lots of fluids because they were shot, they lost some blood or something like that, values of a biomarker called B-type natriuretic peptide, or BNP, values above 110 picograms per ml were predictive or were associated with pulmonary edema, fluid accumulating in the lungs. In short, what they were proposing was this. You gave too much fluids, the heart muscles stretch excessively, and they release BNP. BNP is released to actually alter the sodium concentration in your blood to reduce the fluid volume to adjust what's your body's way of auto-regulating your fluid status. It's used normally, BNP that is, as a marker of congestive heart failure. But can we use it for fluid resuscitation? Seems like we can with this paper right here. Let's look at the other end of the spectrum. Acute kidney injury. If you're not giving a patient enough fluids, their kidney's going to get mad. That's the first organ to get upset. There's several biomarkers out there that have been proposed. The big one that's out there now is NGAL. I'll define it on the next slide. And statistically, it's been shown to be very predictive of acute kidney injury with an odds ratio of 3.73. Where we're going to go with that is NGAL stands for neutrophil gelatinase associated lipocalin. The name kind of implies where it more or less comes from. It comes from neutrophils. Are you guys familiar with neutrophils? They're your major component of your white blood cells. So during inflammation, NGAL is released, okay? NGAL, right here, coming from these white blood cells right here, is filtered by the kidney. If your kidney's not working well, it's going to reduce its filtration. The blood NGAL levels will then go up, okay? What's also very interesting is these nephrons. These are the functional units of your kidneys. Those cells start producing NGAL too. Normally it does not. The NGAL produced by your kidney ultimately are able to be reabsorbed to some extent into the blood, increasing the amount in blood, but also increase the amounts in urine. Okay? So this biomarker will increase substantially in blood and urine during kidney dysfunction. Okay, is that fair? So we hypothesize here that BNP and NGAL working together are predictive of inadequate resuscitation in severely burned patients. We conducted a prospective observational trial, meaning that we're collecting patients as they come in, samples as they come in, but we're not giving results out for doctors to treat. We looked at 30 adult patients with 20% or more burns at UC Davis. We measured creatinine at the point of care. We measured BNP and NGAL at the point of care. And this is what made my staff members hate me for about a year. They had to test every 2 to 4 hours for 48 hours upon admission. So my two or three researchers were on call, waiting for that burn patient to come in, and they started testing immediately every 2 hours, and they were on 8 and 12-hour shifts to make sure it finished. So very, very challenging study. We finished it and we're very happy about that. Here's some sensors here. So point of care testing at its finest. So this is a point of care creatinine meter. There are other, the same platform can test other types of analytes. What I want to highlight with this sensor is it's a gold electrode. Gold, okay, great, it's not that fantastic, but it's one of the first to adopt the gold electrode to increase the conductivity to allow it to have accurate low volume testing. So 1.2 microliters of whole blood is all that's needed. What's very fascinating is it actually incorporates a 4-well electrode here, which can actually correct for factors that make point of care measurements inaccurate. We've shown since 2000 that things like how many red blood cells you have in your blood can actually alter the results of simple things like glucose, to the point where it actually impacts patient care. These things actually are now top of the FDA's list. Literally this week or this month, the FDA has pulled devices off the market for not being sufficiently accurate for our ICU patients. And this is one of the issues that have come into play that cause these devices that were used to be everywhere to be inaccurate. Other interferences like oxidizing substances, because these electrochemical sensors rely on redox reactions. So if you have these drugs in there like vitamin C and so forth, they alter the electrochemistry of these devices and you get wrong results. Wrong results leads to incorrect treatment and people can die. Another point of care device is by Alair, it used to be called BioSite, and this is a portable system that uses a card-based sandwich immunoassay, and it takes about 240 microliters of blood. We put it in there in about 15-20 minutes. We can test for BNP and NGAL, quantify it. This assay actually was not approved by the FDA, so we actually had to get it under research use only license through Europe. So we were one of the first to have it here in the United States for testing. Let's look at our patients. So these are the patients that were over-resuscitated. So 3 of them were considered as being over-resuscitated out of the 30. Demographics, their age, burn size, fluid rate, their CVP, urine output, mean arterial pressure, creatinine were actually similar to each other. That's astonishing, especially for the creatinine and especially the fluid rate, right? If you're over-resuscitated, the other group should have a higher amount of fluids. We consider those that were over-resuscitated as having that abdominal compartment syndrome. So what happens is when those blood vessels start being compressed, the doctors know that, they actually try to push down and it's so taut, they take them to the operating room and actually cut open their belly and let their intestines come out and they actually secure it. And they wait till the swelling goes down, they can stuff everything back in again and sew them back up. UC Davis was actually the first site to ever do that successfully in a burn patient, and the patient survived. But this is what we classify. It worked quite well. We actually look at the plot here of serial testing, x-axis in time, y-axis in BNP and picograms per ml. This was a significant difference by repeated measures analysis. And we can see this black line, which are the BNP values for patients that have that compartment syndrome. It rose quickly within the first couple hours, right? And these are the normal patients right here. Why did it pop right here? Is probably when the patient was doing better, the blood vessels became less leaky, and that's where the fluids started accumulating. The nurses started turning down the fluids to get them all better again. The BNP did serve as an independent predictor of compartment syndrome in this case. For acute kidney injury, now we're looking at the other end of the spectrum, under resuscitation. The patient didn't get enough fluids. These are the patients that had acute kidney injury. These are the ones that did. About 14 out of 30 had acute kidney injury. Age, burn size, and all these other factors, again, were very similar. The creatinine was not significantly different from each other. That's our biomarker for renal function. It didn't tell me that these patients had acute kidney injury. That's not good. Let's look at NGAL, that biomarker. The black line are the patients that had AKI, x-axis time, y-axis is the biomarker levels. You can quickly see that the NGAL levels shot right up in those patients that were not getting enough fluids, that were going to get AKI over the course of 1 week. And this did serve as an independent predictor of the disease. Okay. So, and of course it showed up at 4 hours. So within 4 hours, possibly, out of these 30 patients, we may be able to identify those that were going to get kidney injury, and maybe we could have done something different. Remember, this is an observational study, so these results were not given to the doctors. So where we're going to go with this is, we're going to define the cutoffs for when we need to act. We may be moving towards doing the interventional study. This is maybe early 2015. to actually randomize patients to get this type of testing and treat them. And then we want to integrate these biomarkers into our app above to help doctors be able to guide treatment using these biomarkers and so forth. Okay, any questions there? All right. So we talked about resuscitation. Let's go into the longer component of patient care, wound healing and infection control. So anyone who has a background in pathogen detection and microbiology here? Okay, so I'll sit on this slide a little bit longer. How do we detect pathogens? We detect pathogens by growing them out. It's been around since Robert Koch postulated the germ theory of disease. We grow bacteria out. If something's there, that's probably what's causing them an infection. It's great. We can detect things that grow. The problem is if it's contaminant from the environment or the patient, it grows too. The theoretical limited detection of culture is it can detect that one organism per ml of sample. But the reality is it actually varies greatly from 3 to 3,000. It depends on the organism, depends on the growth medium, it depends on the environment you grow it in. The biggest problem though is the time. The time it takes from sample collection to giving the doctors the result. We did a study that showed that the time from sample to getting a qualitative result, a yes or no, there's something growing, a gram stain, gram-positive, gram-negative bacteria, takes 10.4 hours. That doesn't help the doctor too much. Add another 16 hours to that, that's when the doctors know what type of organism it is, a Staph aureus or an E. coli. Doesn't necessarily help the doctors too much there. What the doctor needs to know is if it's resistant or not. That's 2 days, almost 2 days after sample collection. That's 2 days of guessing. A study in 2008 showed that every hour a doctor delays in getting the right antibiotic on board increases the odds of a patient dying by 12.7%. That's huge. Then last and certainly not least, you can't collect blood culture bottles, these samples, when the patient's already on antibiotics because you inhibit what you're trying to look for. So this is very challenging for these patients. So let's look at a case review. Usually my bioengineers on our main campus in Davis, they love these because they always are amazed at all the things that go on. I know this is a busy slide. I'll cut it down to keep it simple. But this is a 90% burn patient who was 20 years old, had a motor vehicle accident, had 3rd and 4th degree burns and a neck fracture. I'm going to cut out all the upfront stuff because I want you guys to focus on day 27. This is a timeline right here with this light blue bar over here. Day 27, the patient spiked a fever, usually indicative of an infection. The doctors collected what RC and BC here. RC is a respiratory culture, so they took some sputum out, and a blood culture. They drew some blood to try to grow it out. It was collected at that time. They were worried. They knew this patient was really sick. They added 2 antibiotics on board, and they waited. And they waited. Day 30, it finally grew out an organism called Pseudomonas aeruginosa. It's a very, very potent organism, gram-negative bacteria. And the problem is, by then the patient was in what's called septic shock. Their blood pressure was dangerously low. They required administration of vasopressors. You guys know what vasopressors are? What does epinephrine do? Epinephrine is a vasopressor. Your heart rate goes up, down, stays the same with epinephrine. Or adrenaline, alternatively. Goes up. Blood vessels get smaller, right? All these other things happen. Well, we don't like giving these drugs because your heart rate shouldn't be pharmacologically induced like that. And when blood vessels get smaller, especially at the extremities, you lose fingers and whatnot. And blood vessels get into your kidneys get smaller too because of the epinephrine, the adrenaline response there. And you lose kidney function, you have acute kidney injury again. So it's a cascade effect that we like to avoid, but this guy needed because his blood pressure, his mean arterial pressure was in the 40s and 50s. Normal for us is like 90s and 100s. He has green exudate on the wounds, some sort of green tint on his wounds. Well, Pseudomonas has a green tint to it, so the organism was also on his wounds. His platelet count was 88,000. Normal for us is greater than 120. So he doesn't have enough platelets because it's being consumed by the infection. Well, they kept treating him, and he started to get worse and worse and worse. They added another antibiotic on it, and added another one, and collected another culture which never grew anything out. And then the patient died. That's unfortunate, because it took too long to get results. We didn't know what was there. We don't know if we were even treating correctly. And that was very unfortunate, which leads us into the world of molecular diagnostics. Can we detect pathogens more quickly, more specifically, more sensitively with their nucleic acids? And of course, we know PCR. We've heard of PCR before, polymerase chain reaction. It's growth independent. We have very low limits of detection, and the turnaround time can range between 1 to 6 hours, which is great. So we hypothesized here that we use PCR to detect pathogen nucleic acids from blood and to detect the presence of the organism that's causing infection, as well as occult infections, infections that blood culture can't detect. So we looked at 50 adult trauma, emergency, and burn surgery patients. The burn patients, again, have burn size greater than 20%. It was just at UC Davis. It was observational, once again. We did not report the results. This was not point of care anymore, because now I have to sit there. This was my PhD thesis. I had to pipette for about 2.5 hours to get the DNA out and run it. And we took 1.5 mLs of blood, ran it on this assay called the septifast assay. And septifast is from Roche Diagnostics. And it looks at, on a pathogen genome right here, remember it's circular DNA for bacteria. They looked at the internal transcribed spacer region. What's important here is it's usually replicated multiple times on the genome. This improved the sensitivity assay. You're looking for, rather than one needle in the haystack, you're looking for multiple needles in the haystack. That's pretty much the analogy that I like to use. It can detect the top 25 bacteria causing sepsis, including fungi. Here's the gram-negative, gram-positive bacteria, including Pseudomonas aeruginosa. And we did use it in that patient. So you can see here where the arrows are. We ran the PCR. We found out that it was Pseudomonas aeruginosa day 27, 5 hours after collection. What was fascinating was the sample right here, which ended up being named by blood culture, we detected the presence of nucleic acids of that organism too. But in short, what we found here is that the PCR method can detect this organism 38.7 hours earlier and potentially could have identified an occult infection during antibiotic therapy. Going back to that first slide on blood culture, remember, blood culture doesn't work when you have drugs on board that inhibit the growth of the organism. So it's possible that this patient continued to have an infection that culture could not detect. So here we are. This was about 2008. And we have a couple questions. First being, how does PCR pathogen detection impact outcomes? It was an observational study. I can go, yeah, I saved 2 days worth of detection time, but the doctors didn't act on it. So we don't truly know if that can improve care or not. And then, what about point of care? Why can't I detect pathogens as close as possible to the patient? Could that accelerate treatment? And then, what is the clinical importance of detecting pathogen nucleic acids during treatment when cultures are inhibited? Remember, PCR detects only the nucleic acids. I could have killed off the bacteria, their DNA is all over the place. The organism's dead. Does PCR, does nucleic acids really matter? Can it serve as a marker of infection? This leads into kind of what started my career in burns, and this was a Department of Defense study. It's actually still ongoing. And we attempted to look at a rapid PCR-based method, and we were going to quantify the amount of DNA in Staphylococcus aureus in burn sepsis patients. And I quickly realized that, for those in the future when you go into academia and whatnot, one day you'll get a grant, and you get really excited on that day. You get that email, you got the grant. Then the next morning you wake up, you then have the shock of realizing you have to finish the grant. That's pretty much how I felt with this. And so, all of a sudden, it's 240 patients that I needed to enroll. It's a randomized controlled study. 120 will get no PCR testing at all. They'll just be treated like normal. Another 120 will get PCR testing if they need it. And they'll be both treated like normal, the same drugs and everything. They're all adults, all with 20% or more burns. We have 6 burn centers involved. So, UC Davis, the primary site, I'm the principal investigator. We're adding a 7th site at Wake Forest in North Carolina. But you can see here, University of Washington, Nathan Spear Burn Center, University of Miami, University of Cincinnati, and Torrance down in Southern California. And we're looking at Staph aureus. You guys have heard of MRSA. You guys heard of MRSA in the news? We want to look for that too. Methicillin-resistant Staph aureus. It's the evil twin brother of Staph aureus. And Staph aureus right here, very common. It's probably growing on your skin right now. But when you have a destruction or destroyed barrier to the world, such as a burn injury, those organisms are going to become bad. They're going to climb in and cause infections. We're going to focus on a different region of the genome for these organisms. It's about right here for Staph aureus. And we can detect what's called the MEK-A gene that's for resistance to methicillin, an antibiotic. You might be familiar with this system because Pete Daly used to work with this company. And this is the Gene Expert platform. out in Sunnyvale. And we brought this in. It's portable enough for us to bring near to the patient, so almost point-of-care testing in our case. We can test blood culture bottles. We can test wound swabs and nasal swabs in about an hour, and we can accelerate treatment very quickly. So this is preliminary data. It's part of our routine interim analysis. If any of you end up doing a clinical trial, you might have to do an interim analysis to look at how well your study is going, how safe it is, and so forth. And this is some of the data right here. We're actually at about 160-something patients now. This was earlier in the process. We're not due for another interim analysis for another 6 months. So we don't have the data yet. But burn size, age, how long they stayed in the ICU, the number of bloodstream infections, or BSI. MODS is the multiple organ dysfunction score, their disease severity when they were admitted, and their days on the ventilator are all similar to each other. That's what we want to see, because that means randomization worked. Okay, so we're effectively letting the computer decide which patients will be in treatment arm and those that aren't. And we want these to be comparable. We also see that gender was similar, however, more men were burned than women for whatever reason. So we're slightly skewed in terms of gender in the burn care field. And we also see the number of infections for MRSA and regular Staph aureus, so methicillin-sensitive Staph aureus, to be similar. That's also what we want to see, because if a person keeps getting more and more infections, that's going to skew the data set. So these two groups were very similar. But what is fun for us to see, what we're happy to see, is first off, vancomycin, which is an antibiotic that's used for treating MRSA, there was a significant reduction on the number of days used for vancomycin in groups that had our PCR testing. Why is that? Well, what happens when a doctor, you come into the hospital, they're worried that you have an infection, they're going to start you on vancomycin, because they assume that you might have MRSA until proven otherwise. Well, how long did it take for cultures to come out with resistance results? 3 days, about 2 to 3 days. It's about that long. So if you can get something up front to identify that the patient did not have MRSA, you can save between 2 to 3 days worth of antibiotics that may not be needed. So that's what we're seeing right here, because all these patients, as we saw, we quickly identified that they did not have MRSA. The doctor goes, okay, take off vancomycin, let's start on naxillin. This is why we see an increase of non-vancomycin antibiotics in the PCR treated group in the white boxes right here. And that was a significant difference. This is the fun slide that we also like to see too, how fast PCR was against culture. We blow it out of the water, as you would guess, because we measure culture in terms of days, PCR is measured in terms of hours. Okay? Well, let's get more personal. Let's look at a patient case. We like patient cases because it kind of takes it home a little bit more. We have a 40-year-old man with 20% TBSA burns to the head, neck, face, and so forth. This was a house fire. And what we see here is on day 5, the nurse called me up and said, this gentleman has what looks like to be a wound infection on his face. The wound doesn't look that great. So the resident physician ordered a swab. They collected one swab, they sent it to the micro lab for culture. They gave me another swab, I ran on the PCR. This was at 1900 hours. At 2005 hours, we were already able to identify that it was regular Staph aureus, not MRSA. By the way, they already started them on vancomycin. Right here. They already started, right? And we were able to quantify how much bacteria is there, 1,029, based on their nucleic acid count. On day 6, the doctor finally said, okay, let's finally treat for that wound infection. They put a topical on it called mupirocin. I actually collected a sample before that. We actually see the numbers of bacteria actually increasing because they haven't started treatment yet. They started treatment here at 20-30 hours. This is day 6, now we're moving to day 7. Microbiology finally called back and says, hey, there's gram-positive cocci in that swab. I have no idea what that means. Right? That doesn't tell the doctor anything. They don't tell you that it's a resistant organism. It doesn't tell you if it's a E. coli or Staph aureus. We did another quantification of how much is there. We actually see the number half down to 792. Treatment was started the day before. So this is a good sign. And we also have pictures of the wounds healing up. So visually and laboratory-wise, we're able to see improvement from treatment. Finally, on day 8, the microlab comes back and says, it's Staph aureus, but we don't know if it's resistant or not. We're still testing. Remember, it takes a couple days for that. We see the continued decrease in the number of organisms, and finally on day 9, the microlab came back and says, yes, it's MSSA, methicillin-sensitive staph, regular staph. Well, we told them that 4 days earlier. So PCR, in short, was able to provide definitive results based on nucleic acids 4 days faster than culture. We also saw a marked improvement in the patient's wounds during treatment as measured by our quantification of nucleic acids. And we also see a decrease in those nucleic acid counts as the patient did better. So this is supportive of our hypothesis that we could use nucleic acids as a way to quantify treatment efficacy. All right, so in summary, point-of-care electronic burn diagrams, such as the Len Browder, can improve how we calculate burn sizes and estimate burn sizes with accuracy. We can improve the automation of fluid calculations and reduce mathematical errors. And then, of course, these point-of-care biomarkers for BNP, NGAL, creatinine helps us be able to determine how well a person is getting fluids and also detect quite early acute kidney injury. Okay? In terms of pathogen detection, molecular pathogen detection, we kind of know this now, we're in the world of molecular testing now. It does accelerate treatment decisions, especially during sepsis. We can see that pathogen DNA may be able to be used as a surrogate for treatment efficacy, antimicrobial treatment efficacy. And point-of-care pathogen detection by PCR could reduce unnecessary antibiotic therapy, especially with, say, vancomycin. And lastly, we also see that rapid PCR testing of wound infections could accelerate treatment decisions by several days. That's a really good unit of measurement. I can save many days of the waiting game. Where we need to go, and this is why I'm also here today to talk to you at UC Berkeley, because we would be delighted to partner, collaborate, or just involve you in terms of a learning process to figure these problems out. And there's many, many more, but this is just from our burn team. And we need more accurate burn size assessment. So going back to that picture of the rule of nines, that's the ideal person. Do Americans look like that today? No. We could have a person with a certain area of the body be 20% alone. So we don't have a way to personalize how we calculate burn size. We need that because we need to move towards personalized medicine and improve how we resuscitate patients. And remember, when calculating body surface area, that's also the basis for drug dosing. Okay? Chemotherapeutics and whatnot are based on body surface area. In vivo, in vitro, point-of-care real-time methods to monitor wound healing. So these patients sit there for a couple of days after surgery, and they can sit for 5 days with the wound dressings on because the doctors don't want you to take the dressings off and not disturb their grafts. But during that 5 days, it could be when they're blind to potential infections. They may not know if the grafts are fully healing. We need ways to monitor for that. Point-of-care methods to objectively determine scar tissue compliance and guide medical or surgical management. Rehab phase. Patient goes home. They get something called hypertrophic scars. They protrude up, and how they manage it, whether it be surgical or medical, a doctor comes in and goes, touches it, pushes down on it, and they subjectively go, that might need surgery, that might need this treatment. We need better ways to quantify objectively how these work. We need closed-loop point-of-care systems to facilitate fluid resuscitation and critical care management of burn patients. We still wait half a day for a patient to come in from wherever it may be. If a burn patient happens to occur here in Berkeley, and they might get sent to us at UC Davis, it takes several hours to get to UC Davis. All that time, we need someone to be able to come up with a system to improve care by taking measurements of the person's physiological response and then transmitting that data to guide the fluid resuscitation. Why not have a computerized burn surgeon there next to them? The military loves that idea because soldiers burned in the battlefield need to be resuscitated back on the airplane coming back to the United States. The question here is, if we can make an autopilot to fly an airplane, wherever it may be, from point A to point B, or even land an aircraft carrier, I'm not sure if you guys have seen that, but there's now drones that can land on an aircraft carrier. Why can't we use computers to have an autopilot for fluid resuscitation? We can. So lastly, development of point-of-care biosensors for detecting pathogens. We got PCR, but we need to make this smaller, make it more bedside capable. So we have to have ways to detect this. This is not just for burns. If you can do this, you will be rich beyond imagination because we need this in disasters, in the battlefield. We need this in hospital clinics, rural clinics, all over the world because infections are still there. In fact, sepsis, I believe, is still number 2 cause of death in the United States, second to heart attacks. So it happens a lot. Well, I'm not the only one doing this. For these projects that I think you guys embrace this too here at Berkeley and with UCSF, we work together with a multidisciplinary team. It's just not me in pathology, it's me plus our chief of burns, our director of burns, our burn nurses, we have research nurses, physicians, fellows, scientists, and so forth. And we also have our data coordination center with other research nurses there, statisticians, and so forth. So we have a very large team. We have med students, and so forth. So we all work together. We definitely would love to work with you as well. So if you have any ideas, especially as it pertains to critical care, point-of-care testing, and in burns, we're happy to entertain them, and we're happy to work together with that. And now I leave it open for any questions. Thank you.
Yeah, question about the creatinine biosensor.
Yeah.
You said it had 1.5 microliters of
1.2.
sample size.
Yeah.
As engineers, we're kind of obsessed with optimizing something to get the sample size as small as possible.
Yeah.
But is there any real, like in this case, when you don't have to transport the blood a long distance, you just have the patient there. Is there any real difference between that and a sensor that could handle like 150 microliter sample size?
Sure, that's a great question. So it's both a workflow patient thing. So let's talk about neonates, preemies, not a lot of blood volume. And the smaller the blood volume, the better. Now, when we talk about accuracy, it's a little bit different, but in terms of blood volume, huge thing. Burn patients, actually almost any ICU patients, they go in there, whether or not they have surgery, their actual blood, red blood cell count shows them as being anemic. Is that due to their disease? Usually not. It's actually due to them being sampled every day, twice a day, for samples, and we're bleeding them dry, iatrogenic blood loss, and then you tie that into, well, patient's hemoglobin is now at 7, that's when we transfuse, we give them blood, and we feel that giving blood today is safe. It is relatively safe, but there's things called transfusion-related infections or interactions. You can have lung issues from some of the antibodies that might be in donated blood, so we want to avoid that. So on average, I think during a sample collection process for laboratory testing, not point of care, they lose about 10 to 15 mLs of blood. And if you do blood cultures, add another 40 mLs to that, because each bottle, and you need 4, requires 10 mLs of blood. So the smaller the better. And looking at from neonates, they don't have that much blood on them. So they need that smaller amount. And now in terms of accuracy, the larger the sample, you might have issues with dilution factors and whatnot because of just the volume of the sample. You have to spin it down, get the plasma and whatnot. That's how it works in the clinical lab. If you guys are interested, ever up in the Sacramento area, I'm happy to give you guys our tour of our clinical lab. We're highly automated. We're newer than UCSF because we just built a new lab. So we have all these robotics going on. It looks great. But at the end of the day, point of care testing will still be faster and more accurate because it's right next to the patient. And so with that smaller sample, with a highly conductive electrode, you are able to measure those very small amounts of those creatinine molecules in there much more accurate. Hope that answers your question. Good. Other questions?
So you're talking about the new point-of-care sensor for, I'm not sure what model, but you're saying that it had multiple wells, and so could you explain the mechanism of why it's more accurate?
Yeah, so let's go, I'm happy to send papers on this because we're one of the groups that studied this extensively, and the paradigm is actually glucose. And glucose and the other molecules are very similar because they are usually soluble in the liquid phase of blood, which is plasma. So let's look at it from a glucose standpoint, even a creatinine standpoint. Red blood cells will, so you put the drop of blood at the top right here. Hit it with a laser. Up here, you put the drop of blood here, and the blood will come in by capillary action and will go over these wells. And so the problem is, glucose, creatinine, all that, they sit in the plasma phase, outside of the red blood cells. So in a patient with lots of red blood cells, for whatever reason, because you're dehydrated, you have a high red blood cell count, what's called hematocrit, you're going to have the issue of mechanical impedance of the molecules to get to the sensor. So your devices will potentially, without some sort of correction, will read artificially lower. Does that make sense? So less glucose getting to the sensor. How the sensor works is there are enzymes here that will generate that redox reaction, and then the electrons will move towards the electrode, generate the current. It's an amperametric sensor. That's how it measures it. Let's look at it from the other end of the spectrum. A patient, like a surgical patient, who has low red cell counts, they're anemic now. Well, you still have the same amount of glucose or creatinine in the sample, right? And, well, based on Fick's law of diffusion, you now have less stuff in the way. More will actually diffuse into the sensor. You can potentially read artificially higher results when you compare it to some kind of gold standard. What we use for our gold standard for, say, glucose and creatinine in the hospital, it's actually plasma. We actually remove all the red blood cells and test it directly from the plasma. These devices test directly from blood, unspun blood. Okay? So that's where we can have some of those inaccurate measurements. So for glucose, and you know when diabetics need insulin, if you read artificially high, you may give them too much insulin, and they may drop too low in their glucose and die from that. Since these are also enzymatic reactions that generate electrons through the redox reaction, if you have something like ascorbic acid, vitamin C, which is very common, it's an antioxidant. It starts gobbling up all the electrons, and you'll have an erroneous result on these devices. So these sensors right here will correct for that, these different wells. The hematocrit side, the red blood cell side, actually uses impedance. So the amount of red blood cells that's in there, the impedance will change and it will correct for that. It's actually a linear relationship for hematocrit. For the oxidizing substance, it's proprietary, but short, it will detect the presence of that oxidizing substance and measure how much it is altering the chemistry and automatically adjust based on the software on how much to correct the actual sensor. That's it. It's pretty straightforward. This is currently the only device that has this out there. There are other devices that claim that they do autocorrect, but right now it's a major battle for glucose to have these accurate devices in the hospital because FDA is on top of them and saying, if you're not accurate, get out of the hospital. Because a lot of hospitals over the past 50 years have been using potentially inaccurate devices, and the FDA has caught on. And what we see from the data for a creatinine device or any other devices from this manufacturer is it compares quite well to our lab. Does that make sense for the sensor? And if you have other questions, just email. We can send you a couple literature on that if you want to learn more about those biosensors. Other questions? You had a question?
Oh yeah, so you emphasized on like the acute kidney injury. So I was wondering why you focus more on like the kidney itself. Is it because of the loss of fluids that's a really important component of burn injuries, or is it just that it was the one organ that you were focusing on? Like
it actually is one of the most common issues that come up in burns. So the big ones for burn patients is infections, acute kidney injury, and those are the big ones. And then pressure ulcers come next. I think Amy and I talked about that. We'll get to that one next. But yeah, acute kidney injury, just because of the fluid redistributions in the patient from the early phases, they might not get enough fluids, they'll get acute kidney injury. If they get sepsis, their blood pressure drops too. They'll get acute kidney injury. You can also look at it if you want to get more complex. We didn't have time to talk about this, but we have something what's called cardiorenal syndrome. The heart and kidney are actually very much intertwined, more than just being connected by blood vessels. If the heart is having issues pumping blood because you're giving too much fluids, then the heart won't pump well, blood won't get to the kidney adequately, the kidney will become injured from that. If the kidney is actually injured, right, and its filtration drops, because usually when the kidney gets upset, its filtration function drops down, we accumulate fluid in the bloodstream, causing the heart to be overburdened by the fluids and causing the heart to become dysfunctional. So these two guys are interrelated. That's why there's a little bit more to this, but hitting on from burn patients, acute kidney injury is really top of the list. In fact, even in trauma patients, medical patients, acute kidney injury is actually a pretty big thing. It also is one of the primary causes of what's called chronic kidney disease, especially in the elderly, because grandpa, grandma comes in because they were dehydrated, out working in their garden or whatever, and as you get older, your kidneys get more sensitive. You have acute kidney injury, we fix them in the emergency department, give them fluids. Months, years later, they go into chronic kidney disease because their kidneys aren't as receptive to injury anymore, and they now have potential for proceeding down a pathway that can't be fixed. And so it's a very huge issue. So it's not just because we focus on kidneys, but because it actually is one of the top issues in burn care. Now in terms of pressure ulcers, whoever wants to work on that, burn patients get pressure ulcers all the time. And we want to be able to look for that because they lay there for a long time. And the tissue that they're laying on is fragile. They don't have much fat anymore because they've metabolized it all, and they can get pressure ulcers. Pressure ulcers are also big and everywhere else in the hospital too. We want to prevent them, or we want to treat them adequately. Does that answer your question?
yeah.
Other questions?
I was just curious about what the sort of instrumentation costs, so the upfront buying the instrument, but also the per test cost of the two.
Sure.
point of care instruments.
So these guys, we're probably talking between 80 cents to $1 per strip. So they're pretty cheap, even though they're gold. We joke around we should melt them down and then hopefully make some money off it. My students just finished a study that actually looked at these interferences. She tested about 7,000 measurements over a week, so it's a stack of these gold strips. But they also are contaminated with blood, so we don't want that. The other sensor, this guy's about $30 to $60 per card. Starts going up. These enzyme-based immunoassays, they get a little bit more expensive. They can get quite pricey. BNP, we actually run it in the hospital lab. It's actually the most expensive test we run for this side of clinical chemistry. There are more expensive tests out there, though. Genetic testing being one of them can be as expensive as $15,000 if you do sequencing per patient. But for point-of-care devices, if you ever want to go into industry and start thinking about how much to charge for it, for these types of tests, it's usually about $30. For these little point-of-care handheld disposable strips, it's probably between 50 cents to $1 per strip, and that's pretty gets a little bit pricey. But then when you talk about hospitals acquiring these, it becomes volume-based negotiation. So University of California overall, so UCSF, UC Davis, we have a Roche-based glucose meter, and they've negotiated the price down considerably because the whole UC system orders tons of these.
And how much is the reader cost?
The reader depends. I think this guy's probably about $5,000, and this one's probably like about $300 or so for this one. And so, and then there are smaller ones. The model for this, though, especially for home use, so you see glucose meters on TV where they advertise it. They actually sometimes just give it to the user. Here's a free glucose meter. You just buy our strips. So it's the inkjet model of medicine in this case. Other questions?
Okay, so why is the other device not FDA approved?
This one?
Yeah.
So this one is because they chose not to. And the reason is that they're probably, so if you want to go back to the history of this company came up with a sepsis biomarker assay that included NGAL and 2 other biomarkers. It failed miserably and didn't detect sepsis well. And so they decided to probably move on and try to continue to market some of this biomarkers. A lot of the NGAL research actually came from Europe too. So, and most devices really go through the European pathway first. From what I've discussed with them is they're still not happy with the performance of this NGAL assay to the point where they want to submit to FDA, and they're going to rework it up. In fact, I think they're even redesigning this whole test card as we speak. So it's really a challenge to get through FDA. FDA does have very tight regulations, and rightfully so, but it's very hard because there's not much of a gold standard to compare this to as well. Because it's either an ELISA-based assay, but when you have not a great gold standard, a predicate device, it's hard to go down the pathway of a 510K approval process where you have to find substantial equivalence to an existing device. And that's probably another reason why they're worried about that. In terms of that septifast assay I kind of talked about, the PCR assay, same pathway. That's not available in the United States either. It's not FDA approved. You can't compare PCR to culture. Culture grows things, it grows many things. PCR only detects nucleic acids for a set amount of organisms. So FDA ruled that these two were not comparable. Regulatory is always challenging. Question?
Okay, when you try to estimate the total body area of the burn, can you take whole body photographs?
We are starting to look into that, and we're trying to figure out a way how we can what's the terminology now to get all the pictures together. It's like that photosynth app that they have to. Anyway, so we've looked into that. I know there's AutoCAD and whatnot have programs that can generate a 3D model from stitching together the photos, and we're looking into that right now. We haven't found the right group to work with for that.
Well, you have to have 100% coverage or to get a good estimate?
The less the photos we can take, the better. Right now with the apps that are available commercially, it's a lot of photos. The more photos you take, the higher the accuracy that is. The less photos we can take, the better, because the nurse is not going to go take a picture, slide over.
So when they change the dressings, when they turn the patient, couldn't they get up overhead and get a pretty big.
And that would be ideal. Yeah, I think if we could do that with an iPad or something, or just normal digital camera, that's possible. So we have some way to kind of stand up or have a pole or something, take a picture.
Yeah, put the ceiling light.
Yep, that would be something that would be very feasible for us. We just have to come up with a way to kind of get going with that. We've been thinking about this idea for probably about 2 or 3 years.
Do you have the software for analyzing the photographs once you've got them?
We have that. It's really the free one, so I don't think we're too satisfied with it because it requires too many photos. But
Well, assuming, okay, so you got two problems. Putting together a montage of pictures to get at least one side of the body at a time. And then you got the problem of doing image processing to analyze the areas. That software has been around for 20 years.
Yep.
That software is not a problem.
Yeah.
It's just getting the photo montage.
Yep. That's pretty much it. And reducing it down. I mean, we could take it really high up. The other problem that we ran into was consistency. So sometimes the rooms might be darker, might be lighter, depending on what's that. But we ran into a problem with the commercial software. It wasn't that great, so we have to kind of find a better software for that. But if you know of anything, we'd love to check it out.
Well, that seems like the kind of approachable engineering problem that should be able to be solved.
And that's where we now we've kind of paused on it because we haven't had a chance to find the right group at Davis to kind of build up on that. That's what kind of came out here because I think that's why I sent you an email. You know, imaging people on this end because that's one of the big ones that we would love to tackle.
Call Pixar. Call Lucasfilm.
Oh, we tried that.
You tried it.
Yeah, we tried that one. Sometimes some of these companies may not be as health oriented as we would like, unfortunately. No, those are there. Yeah, because we've seen the devices that scan. So I can scan this pen and then the 3D printer will print the same thing on the other end. We've seen that.
That's true.
And so, but the 3D models are very, very useful for us because that can also guide drug dosing. Because once you can calculate the surface area off of that, we'll have a very unique tool.
Well, okay, I think if you solve the problem of getting a camera placement where you can see most of the patient in 1 or 2 shots, you have a much easier job.
Absolutely. Other questions? Great. Well, email me if you have any questions. Again, I want to reemphasize, happy to give you guys tours up there or whatever, and then we go there, but I can send you information on the course. We would love to. We're probably going to put up more on YouTube in the future so that more people can access it. And so if there's any topics you guys want us to cover, we're happy to try to figure it out. And those that want to have an interesting topic to talk about, I think we could work out a way for you guys to talk there. You guys want some presentation experience up at UC Davis too. All right. Thank you so much.